list, we have Dr. Miocinovich. Oh, there she is. I was worried I couldn't find you. I thought maybe you didn't make it. Dr. Miocinovich is also at Emory. She's in the movement disorders group. She has an interest in all types of movement disorders, including dystonia, and has a special area of expertise in deep brain stimulation surgery. So we've asked her to come and talk to you about the role of that particular procedure in blepharospasm and MAGE. So let me pull up her presentation here.
Okay, well, I really appreciate the opportunity to speak with you today. So we will go over another surgical therapy that we use for dystonias and also blepharospasm, sometimes in particular. So this is a neurosurgical treatment. I'm not a neurosurgeon, I'm a neurologist, but I spend a fair amount of time in the operating room with the surgeons, helping them during the procedure. So specifically, we will talk about what is deep brain stimulation, or DBS. I will describe to you how the surgery is typically performed. We will then talk about how well it works in dystonias, and specifically how well it works in blepharospasm. And then when would be a time that somebody with blepharospasm might consider DBS. So DBS is frequently described as a pacemaker for the brain, and that's exactly what it is. So it consists of, is it showing up on both screens? Good. So a thin wire electrode is implanted deep into the brain, and typically people get either one or two electrodes, depending if their symptoms are present on one or both sides of the body. So left brain controls the right body, and right brain controls the left body. So this wire is placed deep inside the brain, and then the wire is tunneled underneath the skin, behind the ear, all the way down into the chest area, and then the pacemaker or the battery is implanted underneath the clavicle. And so this battery then sends continuous small electrical pulses back into the brain and helps those motor centers work more regularly or precisely. So you saw a similar schematic of the brain from Dr. Miller. So this is the basal ganglia, those deep nuclei deep in the brain that control motor function. And so this is exactly where we place the electrode, because basal ganglia are at least partially involved in the problem of dystonia and blepharospasm. So here's our little electrode flying in there, so you kind of see this electrode. And so this is the area that we typically target. It's called the globus pallidus. And you may have heard that DBS is used for other disorders like tremor and Parkinson's disease. So then, depending on the disorder, the electrode may be placed in a different part of the brain. So for example, for the tremor, we may place it into this big yellow area called the thalamus, and then for the Parkinson's disease, we may place it into this little area called the subthalamic nucleus. So depending on which disorder you're treating, you place the stimulating electrode into the different part of the brain, but the system is the same. It's the continuous electrical pulses that get sent in. So I still get a question even from other physicians if DBS is some sort of research therapy. No, it's actually a well-established therapy. It was really started in late 1980s. It was first done by a French group for treatment of tremor. And then in early 2000s, 2003, it was FDA approved for primary dystonia. So blepharospasm falls under that, even though the studies were not originally done on blepharospasm, and we'll talk about that a little bit more later. But now it is really considered standard of care for movement disorders, and it is typically covered by most insurances. So this is the equipment that we use. So the brain electrode, you can see it here. It has 4 metal rings. Those are the contacts that the current is passed through. And the size is about thin spaghetti, cooked thin spaghetti, because it's actually flexible. So it flexes with the brain. So if you imagine cooked thin spaghetti, this is exactly what it looks like. And then the stimulator, this is the part that goes into the chest. It looks like the size of half a deck of cards. Even sometimes they're getting much smaller, actually. But it looks exactly like a pacemaker or a cardiac pacemaker, if you have seen one of those. And then here's the clinician programmer. So this is a little computer that we use to set the parameters, the stimulation parameters. And then patients also get their own programmer to have at home so they can turn the device on and off and also adjust it as needed. So this is what the surgery looks like. So you can see the patient is sitting here. Well, it's sort of in a semi-lying, semi-sitting position. And the first part of the surgery, the person is completely asleep. The surgeon uses an MRI to find the initial target. But because the target is so small, it's about the size of a kidney bean, deep inside the brain, it's very difficult to really hit it precisely, and millimeter here and there makes a big difference. So halfway through the surgery, we actually wake the patient up. So the person is awake, and we are using probes that we introduce into their brain to record brain activity to make sure that we are in the right part of the brain. And then we also test, after we place the permanent electrode, we also test it to make sure that we are seeing the appropriate response. So it may seem scary to be awake during brain surgery, but most of our patients tolerate this really well. And here's an example. This is a patient recently. This is one of our surgeons here at Emory. And the patient was woken up. So we were about to start doing the brain recordings. And then he was asking a lot of questions. He really wanted to know exactly what we were doing. So then here, Dr. Gross brought the neurosurgery textbook, this huge book. So they're sitting here together. The guy's head is open, and he's showing him, exactly what's happening. So we have a good time in the operating room.
Were there refreshments?
Yes, we offer little swabs of cold water. People love it. Best water they ever had. But for those who are still not convinced that they would like to experience this awake, there is now DBS surgery that we refer to as asleep DBS. So the patient is completely asleep during the entire procedure. The surgeon is awake. So that's so there's no electrical recordings, there's no testing, but to compensate for that, the surgeon is able to watch the electrode. So the surgery is done in the MRI scanner. This is actually MRI scanner, and so they sterilize it and make it appropriate for surgery. And so the surgeon is introducing the electrode and watching the entire time exactly where that electrode is going. So this is, again, an alternative way of introducing these electrodes, and in experienced hands, both methods are similarly effective. So I always tell my patients that the surgery is the easy part of DBS. It's really what comes after that can be long and frustrating, and that's DBS programming. So that refers to fine-tuning the stimulation parameters, and those can be very different and vary from person to person, and it can take up to 6 to 12 months of fine-tuning to get the right settings. So people typically come every 1 to 2 months into the clinic. We make some changes. They go home. They may do some adjustments at home themselves with their home programmer. Then they come back, report what things are better, what things are worse, and then we repeat that for several months. And then eventually we kind of settle on parameters that work best for that person. So it's important to talk about DBS complications. This is invasive surgery. It is considered minimally invasive, but nonetheless, it is surgery. So the most feared complication is brain bleeding, so essentially a bleeding stroke. This happens in about 0.5% to 2% of people. So on average, 1 person out of every 100 that has DBS surgery will have some bleeding. Now, luckily, this is usually we may just see some bleeding on the MRI afterwards, and the person doesn't have any problems from it, but sometimes it can be significant. People can have weakness and speech problems, and in very, very rare cases, people have died from DBS surgery, so it can be serious. A little bit more common is infection. So about 3 to 10% of people will experience some form of infection. Usually the infection will start around the pulse generator in the chest. And then if we catch it quickly, we can oftentimes treat it with oral antibiotics, and it clears up in a few weeks. Sometimes if it's more complicated or it starts traveling towards the brain, then the surgeon may have to pull out the equipment, let everything heal, and then reimplant everything again. And then after we turn the device on, the device is turned on about a month after the surgery, after the brain and swelling heals, then we can actually induce all kinds of side effects just by turning up the current. So I usually have fun with my patients in the clinic because we purposely actually turn it up all the way because we have to get the thresholds, and then they can get any kind of motor side effects, like their face will start spasming, or they'll feel tingling. So all those are temporary. As soon as we turn the current down, they go away. But sometimes they can be a little bit tricky. Sometimes people may have tingling, and we may not be able to adjust the current so they don't have the tingling but still get the benefit. But usually those are adjustable, and we can work around it. Okay, so now let's talk about, well, how well does DBS work for dystonia and then especially for blepharospasm. So this is a complicated graph, but I really want to walk you through it because this is really a great summary of everything we know about DBS outcomes in dystonia. So here on the horizontal axis are different types of dystonia. I know this is very small, but here, this first one, it says generalized dystonia. And then on the vertical axis is percent improvement. So up here is 100% improvement, so really good, and then here it's really bad. And so everything in blue is referring to DBS. There's some non-invasive green options. And then the size of the circle is how much evidence we have that this is really working. So how many studies, research studies, and how well those research studies were done. So you can see here for generalized dystonia, you can see there are these big circles at about 75%. So about 75% of people who have generalized dystonia, especially this genetic form of DYT1 dystonia, gets about 75% improvement. So this is really what we consider really, really good. Now you can see here cervical dystonia is next. So it's a little bit lower, it's about 50%. But again, 50% consistent improvement in most people. And then here is the cranial dystonia. So this is where blepharospasm falls under. Now you can see here it's actually around 65%, so it's good, but you can see the circle is really small. That means that we really have very few studies that have specifically looked at cranial dystonias and blepharospasm. So the evidence is just not as strong as some of these other dystonias. So I'll show you some videos. Do we have sound? Do we know? Okay. We don't have sound. Okay, maybe I'll narrate then. So this is a patient. So this is not my patient. This was a published study from UC San Francisco. And so this is a patient who just has blepharospasm. And you will see him. I'll play the video. We'll see. Oh, can you guys hear this?
I just can't open them at all now.
Let's see. Can you guys hear it or no? Not really? No, it stopped now, yeah, but I'm just wondering if I should just narrate instead. Okay, so he's basically saying that he's had blepharospasm for about 8 years. He obviously has a lot of difficulty keeping the eyes open. He's now describing his sensory tricks, so pulling the eyes open. And that's very effortful for him, and he can only do it for so long. So essentially, this is an example of a person who is functionally blind most of the time. And then we'll see him 1 year after DBS surgery. You can see it's a vast improvement. So he's actually saying now that he had the surgery and then nothing was really happening for several weeks. He was turning up the current every day, and then he really didn't think it was going to work because he said, I've tried so many things and nothing has worked. And he just thought DBS was just one of those things that, again, didn't work. And then he said one day, it was 8 weeks after he started the programming, he woke up one day and he could tell a difference, and he said by that afternoon it was gone. But it took good 8 weeks of the stimulation to finally kick in. And then, so now they're asking him to close his eye, and you can see that there's still a little bit of excessive blinking, so it's not perfect, but it's definitely a vast, vast improvement.
Actually see a change in that guy's personality.
From just even without hearing him?
Yeah.
Absolutely. So here's another example. This is a lady from Poland. It was a Polish study. So similar situation. She had very severe blepharospasm before surgery. She also has some jaw problems. And then you can see her here with DBS. This was several months after DBS. And you can see her smiling more. So this is good news. The bad news is that there have been a total of 3 cases published in medical journals of people with only blepharospasm having DBS. So we know that there are more people who have had the surgery, but we unfortunately don't know how many exactly people with blepharospasm have had DBS and how those people did. But I can tell you that doctors love to report positive outcomes. So we love to report these cases when good things happen, but we unfortunately don't know. We don't have studies to tell us exactly how often it doesn't work in blepharospasm. But what we do know, we know how DBS works for MAGE, actually. So there's more studies looking at cranial dystonia. So I'm going to go over this with you because this is really a summary of all the studies on MAGE syndrome and DBS that have had more than one patient. Because again, if you have one good patient, that's okay. But you really want to see what happens to a series of patients. So here you can see, it tells you here where the study was done. So you can see it was all over the world: Japan, Poland, US, Germany, Korea. And it tells you here how many patients were involved in the study. So they typically, doctors will say, okay, in the past 5 years, we've operated on 6 patients, and this is what happened to them. So this gives you a little bit of better picture than just saying oh, look at this one guy who did really great. And then here it tells you the % improvement. So you can see it's about anywhere from 50 to even 80% improvement overall. Again, so both eyes and the jaw. And then I separated out just eyes alone if they reported it. So you can see for eyes alone, there was about, again, 50 to about 70, even maybe 78% improvement. But it's important to note, for example, in this study, they had 6 patients, and 2 patients, unfortunately, really didn't get very much benefit. So even though on average there was 60 to 70% improvement, you have to remember that that means that half the patients were below 60%, and then the other half were these great video cases where they may have had 80, 90% improvement. But the other good news is that if the patients did have improvement, then it lasted for years. The follow-up was here even up to 5 years, so the benefit persisted if patients did get the benefit. So there's still really a lot that we don't know about why people with very similar symptoms respond so differently. And so we're still trying to do a lot of research, trying to understand exactly what is going on in the brain. So I'm just going to briefly tell you about a research study that we recently did, trying to understand exactly what is going on with brainwave patterns in dystonia specifically. So here we had patients who had DBS for dystonia, all kinds of dystonia, cranial, cervical, and generalized. And we did brainwave recordings using EEG. So this is the non-invasive scalp recordings to look at those electrical signals from the brain. And what we were looking specifically is to compare how much crosstalk was there between the left and the right hemisphere of the brain, how much synchronization was there. And we were able to tell that when people were off their DBS, so the way we did this studies, we recorded brain activity when people were on their regular DBS, and then we turned it off for about an hour, and then their symptoms slowly started to come back, and then we did another set of recordings. So when the DBS was off, there was a lot of synchronization, a lot of crosstalk between the 2 parts of the brain. And then when the DBS was on, here in red, that crosstalk was much less, and it was actually very similar to control subjects here in black, So DBS was sort of reducing this abnormal synchronization that we see in the brain, and this was particularly prominent over the motor areas here in sort of the middle of the head. Oops. Is these motor areas. So we're now trying to understand what exactly DBS is doing and how can we make better DBS stimulators that may be able to self-adapt and change this synchronization as much as possible and maybe help more people. Okay, so then when is the good time to consider DBS for blepharospasm, and should you even do it? So what I would say is first, you really need a definitive diagnosis by a movement disorder neurologist before you're going to consider invasive surgery. And we already talked about the importance of having proper diagnosis and how easy it is to misdiagnose somebody. Then it is crucial to really give a good try to medications and botulinum toxin. And then if they're really not working, then maybe time to consider surgery. But at our center, you saw how important it was to have an experienced injector who really know what they're doing. So at our center, we'll typically require that people undergo at least 2 rounds of injections with our providers before we would consider sending them for DBS surgery to really show that if it's really not working. And then also, blepharospasm obviously has various degrees of severity, so somebody really has to have significant disability and really very poor quality of life to justify an invasive surgery. And then finally, it's really important to have realistic expectations. Again, these videos, as I said, we always show the very best cases, so you have to realize that more realistically, maybe 50–60% improvement is more realistic to expect, and people have to be able to accept that maybe it won't even work. So really having realistic expectations is crucial for this type of surgery. So to summarize, I think I've shown you today that DBS is an effective therapy for dystonias. We know it works really well for generalized and cervical dystonias. There's now increasing evidence that it also may work for cranial dystonias, including blepharospasm. But the outcomes are variable, and we need to do more research to understand how to improve it. And this is just a hello from our Emory DBS team, and I'm happy to take any questions.
Okay, so we have time for a couple of quick questions, but I want to remind everyone that we have the doctor panel next. So if we don't get to your question, Dr. Miocinovich is going to be sitting right here, and we'll take more. So first hand over here.
Yes, so I can tell you that of the patients that I've known who've had blepharospasm and had DBS, a lot of patients still do continue botulinum therapy. Again, they may need lesser dose or maybe wider intervals, but a lot of people still do need it, and actually they get best result from both. Sometimes people say like, well, botulinum toxin wasn't working as well, but then 50% improvements from surgery, another 40–50% improvement from botulinum, and they do really well.
Yes, good question. Okay, right here.
That's a good question. So the question is about age appropriateness for the surgery. So yes, well, there's no strict cutoff. There are some centers where they say the cutoff is 75 or 80 years. We at Emory don't really have an age cutoff, but we take general health condition of a patient, and then also we require neurocognitive testing to make sure that there's no cognitive problems that would potentially get worse after the surgery. So no strict cutoff, but
let's do one more question over here, the man with his hand up, and then we'll get the panel up here, okay?
Two people standing up. So the question is, does DBS stay in? Yes, DBS stays in typically. I mean, very rarely we'll take it out either for an infection or in very rare cases, if it really doesn't work and the person wants to have it taken out, then it can be taken out. The nice thing is, again, there's no permanent lesion to the brain, so you can always take it out. Excellent question. How is the patient improvement being measured? So a lot of the studies that I've shown you are what are called open label studies, meaning that both the patient and the doctor know that the patient has surgery. You can imagine there's a lot of bias there. If I know you had surgery, I can say, like, oh yeah, you're better, you're better. So they use rating scales, but again, if you know somebody had surgery, you may give them a better rating. I think there was only one study on the list where it was blinded. So the doctor who was rating the patient didn't know whether or not they had a surgery. So that's actually very important to consider.